Hi, today we will talk about secondary amenorrhea, and it is a very important concept to learn, especially for postgraduates and undergraduates, both for your exams and for your clinical knowledge. You get many questions from in NEET PG also, and obviously for postgraduates, it's very important clinical and a very confusing state where you have to reach to a diagnosis so that you manage your patients well. So first and foremost is definition. It is absence of menstruation in previously menstruating female. It means their hypothalamic, pituitary, ovarian, and uterine axis were all normal, but something has occurred now so that she has stopped menstruating. That is one part. Second is when there is amenorrhea or missed periods, then you have excluded out pregnancy. It should be either that her 3 cycles have not come or a total duration of 6 months that she has not menstruated for. So all these things combined together forms the perfect definition of secondary amenorrhea. So I will repeat: one, absence of menstruation in previously menstruating female. Second, you have excluded pregnancy. Third, 3 cycles or 6 months have passed by since the patient has menstruated. So there is a clinical case, a 20-year-old female who is having parity of 1, live issue 1, previous 1 abortion. She presents with secondary amenorrhea. 1 full-term vaginal delivery, she is now not lactating. 1 abortion for which suction and evacuation was done at a private clinic. She is having anemia also. Her hemoglobin is 6 gram percent and she reports breathlessness off and on. So what you have to find out that what has caused secondary amenorrhea in this patient. Very important history, I'll go back to this slide, is that she has had full-term vaginal delivery. It means everything was perfect. Second is, since the time she had this abortion, for which suction and evacuation was done, she developed hemoglobin of 6 gram percent. Since then, she has developed this secondary amenorrhea. So now what you have to find out what thing in hypothalamus, pituitary, ovarian, and uterine axis has gone wrong, whether it is a central cause related to hypothalamus, a pituitary related cause where LH and FSH are coming down, an ovarian cause where ovary maybe has stopped functioning, something else has gone into the uterus to cause it like functioning bad, or there is some problem in her outflow tract, that is cervix and vagina. So while finding out this, first you have to see how should menstrual cycle irregularity, especially secondary amenorrhea, be evaluated. So when we evaluate, as I told, central, pituitary, ovarian, uterine causes have to be ruled out. So we will go to the evaluation, and first and foremost, we will talk about what is required importantly in hypothalamic pituitary ovarian axis. It is the level of follicle stimulating hormone, because if it is there, if there is normal follicle stimulating hormone, it means ovaries and hypothalamus and pituitary are functioning well. If there is low FSH, it means either pituitary or hypothalamus is not functioning well. If it is high follicle stimulating hormone, it means hypothalamus, pituitary are working well, but somewhere ovaries are not working well. And sometimes it's idiopathic, everything is perfect and normal, still patient land into amenorrhea. So essentiality of workup of secondary amenorrhea, first and foremost, is history. Never ever underestimate how history can lead you to make a good, perfect differential diagnosis and lead you to make a provisional diagnosis. So ask first question to your patient, what has been the duration of her secondary amenorrhea, whether she fits into that definition of secondary amenorrhea or not. Second is history of lactation. Patient may never tell you that she is breastfeeding her baby at night time. She says, sometimes, the baby is not letting me go, and there is lactation occurring at night. And this important history is often not revealed by patient. Third is contraception, because it is not unusual that after abortion, we give patients dipomedroxyprogesterone acetate. And for these patients, they land into amenorrhea. So always ask about contraception, especially DIMPA and oral contraceptive pills, Saheli, implants, because all these patients land into amenorrhea. Quite a chunk of patients are landing into amenorrhea. Fourth is drugs. Many a times patients are taking drugs, medicines for other conditions. Landing into amenorrhea, you keep on evaluating without even taking a proper history of drug intake. Very important history is surgery on uterus, that is dilatation and curettage, or suction and evacuation. Because in that category fits the excessive curettage leading to approximation of anterior and posterior vaginal wall and formation of Escherman syndrome, which we will talk about in later segment. Then history of postpartum hemorrhage it is also known as Sheehan syndrome, which destroys pituitary function and thus patient land to amenorrhea. History of headaches and visual defects will give you a clue into the microadenoma or macroadenoma of the pituitary, where excessive prolactin levels are there and patient land to secondary amenorrhea. Then, of course, diabetes and tuberculosis and any other infiltrating diseases, systemic illnesses should always be ruled out. Lactation, when patient is lactating and she is amenorrheic, it is known as lactational amenorrhea. You see high levels of prolactin which suppress ovulation. Endometrium becomes pseudoatrophic, and as long as 3 to 4 years also, if patient is lactating, patients are having amenorrhea after that. There is no need to assess secondary amenorrhea caused due to lactation by measuring serum prolactin level, because we already know that they will be high. So treatment, stop lactation if patient is anxious, and in some cases you may prescribe cabergoline to suppress breast milk. So first and foremost, even in this patient or in this category, you have to rule out pregnancy. After that, you have to see whether patient is lactating. There is no need to do a serum prolactin level. Second important is contraception, long-acting agents like dipomedroxyprogesterone acetate, centrochroman, implants, even LNG IUS. And as I told earlier, patient usually does not give history unless specifically asked. So be very specific. Take this into second number for your history taking phenomena. So how do you treat it? It's always by reassuring them. And for DIMPA and implants, amenorrhea may last for longer time even after their removal. And for centrochroman, it may persist for 6 to 8 months. But yes, this is not the rule of the planet. The resumption of menstruation, ovulation may be earlier also. Drugs, especially antipsychotic medication, again, this is a taboo. Not many patients will tell you that they are on antipsychotic medication, antihypertensive medication, especially young girls. So they will never ever tell you. So you have to be very specific in asking about these drugs and prescriptions. Sometimes patient does not even know that they are taking antipsychotic medication. So this history is very important. Ask what she has been taking, whether it is off and on or a regular one. See the packets where she is bringing along with her. Treatment is either dose reduction after consultation with psychiatrist, or you may change her medication so that amenorrhea is, broken down and the cycles are restored. Now, as I was talking about surgeries, oophorectomy, suction evacuation, or gynecological curettage, you have done dilatation and curettage. There was an endometrial biopsy and associated excessive curettage of the endometrium, or patient has undergone a peripartum hysterectomy. Again, patients will never ever tell you that, yes, she has undergone peripartum hysterectomy, because sometimes patients are belonging to poor socioeconomic strata landing into PPH. Obstetricians have to resort to obstetric hysterectomy. And these patients, the family, they conceal this history that you are no longer having a uterus. So she presumes that she's having uterus, and then she becomes anxious and come to you. So always take a good history, and especially if, regarding these surgeries, family people are better persons to for eliciting this history. Very important entity is Escherman syndrome. It is due to almost always and universally due to excessive curettage. Basal regenerative layer is denuded when we are putting the curate and curating out the endometrium. We almost destroy basal layer from where regeneration of endometrium occurs every month. Thus, in this process, when we excessively curettage in order to heal themselves, these walls are adhering themselves to each other. Other important etiology, especially in our country, is infection, tuberculosis. Endometrium is destroyed. Consequently, there is formation of adhesion in between these two walls. Sometimes after manual removal of placenta, we excessively, take out the placental chunks and pieces, and thus patient land into Escherman syndrome. And endometrial ablation, which is a good treatment for heavy menstrual bleeding when we have lesser options at hand. Then also patient may have Escherman syndrome development due to the destroyed endometrium is trying to heal itself by approximating with another wall. So this history must be elicited. We classify Escherman syndrome in various methods, but the most important ones are first location wise. It means where the locations or adhesions are located into the uterine cavity and endocervical canal. So when we talk of location, first is intrauterine fibrosis, only fibrosis, without visible adhesion or obliteration of the cavity. And as you can see, the endometrium over here must be fibrosed, but there are no adhesions in between these two uterine walls. Second is only cervical canal adhesion, and this leads to atretic amenorrhea. So you see the entire endometrial cavity may be okay over here, but there are certain fibrotic bands developing into the endocervical canal. Third is our out and out uterine cavity adhesion. One is central adhesion without obliteration of cavity. Second is partial obliteration and constriction of the cavity. And third is complete obliteration of the whole uterine cavity, as you can see. Fourth category is uterine cavity combined with cervical canal adhesion. This obviously is the worst one, where endocervical canal and uterine cavity, everything has been obliterated by dense adhesions. Second classification is Marsh classification, in which we quantify the amount of adhesions that have been formed. So first was almost a topographic division, where there was fibrosis without adhesion, only endocervical canal adhesion, uterine cavity adhesions, and fourth is the adhesions of the uterine cavity as well as endometrial canal. Second is a degree-wise classification, which is also known as Marsh classification, which is categorized into minimal, that is less than 1/4 of uterine cavity is involved in adhesion. Thin or filmy adhesions are there. Ostial areas and upper fundus is minimally involved or clear. Then second is moderate, where 1/4 to 3/4 of the uterine cavity is involved. There is no agglutination of walls, just adhesions. Ostial areas and upper fundus is only partly occluded. And in cases where cavity integrity has been restored, but ostial occlusion still exists, a classification of moderate applies, right? Final is severe, where more than 3/4 of uterine cavity is involved. There is agglutination of walls or thick bands of adhesions have been developed. Ostial areas as well as upper cavities completely occluded, then we call it as severe degree of Escherman's. Now a question here for you guys. How do we diagnose Escherman syndrome? Like how do we either topographically analyze it, or how do we see whether it is minimal, moderate or severe? Do leave your comment in the comment section. So here is the answer. You see first picture, this is a very beautiful picture of HSG, that is hysterosalpingography. So you see uterine cavity over here, it is slightly distorted, and you see filling defects over here. So dye has entered all the areas in this place. It has traveled into this fallopian tube also, but you see filling defects, and this is moth-eaten appearance of the uterus, which we see typically in an HSG picture, classically diagnostic of Escherman syndrome. Then you see second diagnostic modality is hysteroscopy. Yes, you put your endoscope directly into the uterine cavity. You see either filmy bands or thick bands or whatever topographic bands in the endocervical canal. Ostia are open, but the mid cavity is obliterated by the adhesions. Then you quantify either mild, moderate, or severe, and then you topographically analyze where your adhesions are lying. Treatment is, first you have to evaluate history, then do an examination, then either use office hysteroscopy to confirm the diagnosis and identify the extent of adhesions. Operatively, you can do cervical and uterine dilatation, adhesiolysis of uterine synecdoche. Sometimes you may put hyalurobarrier gel into the uterine cavity. Sometimes you place intrauterine balloon catheter, which I normally put. I take pediatric number 8 catheter. I do hysteroscopic adhesiolysis. If the adhesions are flimsy, there is not much problem. But if the bands are thick, then you have to really cut them through. There is slight amount of bleeding also. And to stop the bleeding as well as prevention of re-adhesions, I put this Foley's catheter inside the uterine cavity. Post-operatively, we remove the balloon catheter after 1 week of surgery. And this is again not a rule, but office hysteroscopy within 2 weeks after the surgery. Some people do it after 4 weeks also. Again, estrogen supplementation for 8 to 10 weeks after office hysteroscopy is actually, all obstetrician dependent, whether she wants to supplement or she does not want to supplement, because there is no strong evidence for in either to support this supplementation. So the theory behind estrogen supplementation is it regenerates endometrium and helps in healing and thus formation of future endometrium. Then, yes, if your patient is having infertility and secondary amenorrhea, then after this, the correction of adhesions, IVF, ET can be planned provided sufficient endometrium has developed anything more than 5 to 6 millimeter. If uterine cavity is completely obliterated, then in cases of infertility, there is no treatment for her secondary amenorrhea, then she can go for either surrogacy or in extreme cases, uterine transplant, which is not only costly, but very intricate surgery requiring lot of expertise. Not many cases have been done, but yes, cases have been done successfully, and it's a beautiful surgery to look at. So Escherman syndrome, basically treatment, you first see where the adhesions are. Second, what is the degree of adhesion? Third, using a hysteroscope, do a guided adhesiolysis, put some occlusive barrier, which is usually and mostly a Foley's bulb, remove it, and after that you can either do a second look hysteroscopy or you can do a NHSG also. Now, I was talking about Sheehan syndrome, which is a sequelae of postpartum hemorrhage. Due to massive postpartum hemorrhage, there is deficient blood supply to pituitary gland, which leads to necrosis, and thus there is profound pituitary gland dysfunction. As you can see in this image, see how this pituitary gland is controlling us. Anterior pituitary releases growth hormone, which is important for bones, muscles, and other organ growth. Then prolactin is released, which is maintaining, as you all know, lactation and important for development of breast tissue. LH and FSH, you already know these are gonadotropins, and they help in follicular development and recruitment and ovulation. ACTH acts on adrenal cortex, releases cortical hormones, and maintain all the endocrinological functions. Thyroid stimulating hormone acts on thyroid gland, and thus we have a beautiful thyroid hormone functioning well, controlling our BMR and everything. Then posterior pituitary, it releases vasopressin, which is antidiuretic hormone, functioning on kidney, maintaining the GFR and urine output. Posterior pituitary also releases oxytocin, which is again important for uterine contraction during delivery and maintaining lactation reflex. So if this anterior and posterior pituitary is destroyed, see the effect that the body is going to have. So this Sheehan syndrome classically presents as history of postpartum hemorrhage. That is one. Always remember, whenever you are talking about Sheehan syndrome, patient will give you a history that she has had massive postpartum hemorrhage. Then she can have failure of lactation due to decreased level of prolactin. Then she can have breast atrophy due to decreased level of estradiol. She will have amenorrhea because she will have less amount of follicle stimulating hormone, and consequently there will be less estradiol and progesterone, and thus uterus endometrium will neither be regenerated nor will be shed. Then her blood pressure will be consistently low because ACTH is not there and there is decreased production of cortisol level, and she will be having hypothyroidism also. So these are the classical features of Sheehan syndrome: history of PPH, amenorrhea, breast atrophy, failure of lactation, decreased blood pressure, and hypothyroidism. Then clinically, axillary hair will vanish in such a patient. There is diabetes insipidus, all the features associated, shock in acute cases. But yes, you must remember they will always have low blood pressure and there will be appearance of wrinkles on the patient's face. So diagnosis, I stressed earlier also, massive postpartum hemorrhage. She landed into shock. There was history of blood transfusion and everything. When you examine this patient, there is defeminization like atrophy of breast and loss of pubic and axillary hair. The test that you have to undertake will reveal that there will be low FSH, there will be low TSH, there will be low cortisol, low prolactin, low testosterone, and low estradiol because pituitary gland is not functioning. Treatment, you have to replace all the hormones like thyroxine, steroid hormone, estrogen in the form of oral contraceptive pills can be given. Thus, her uh, menstruation will be restored, her BMR will be restored, she will feel better clinically also, and in the formation of resumption of menstruation also. So I'll stop my lecture over here for today's. Tomorrow we will talk 3 or 4 more causes of secondary amenorrhea. I'll be posting questions also. Feel free to communicate and resolve your queries also. And I'll be solving happily whatever queries have been put into. Thank you.